Hello, everyone. Good evening. Welcome to the Plainfield Town Hall. My name is Rob Taylor. I am going to be your sort of host slash moderator this evening. We're so glad that you've come, and we welcome you to this beautiful historic structure here in the town of Plainfield. Hopefully you've had a chance to get some food and some snacks, and there's beverages and water. A few announcements. The bathrooms are right as you came in that sort of foyer in the front of the building. The exits, you can see there's exit signs here, so if you need to get out of here quick, there's an exit there, and an exit over there, and one back there. I'm your flight stewardess here to help you. A couple things to start out with. We want to thank you all for coming, obviously, and we're going to have an opportunity to hear from I think a very impressive panel before you, and I will introduce them in just a moment. And a little bit later, after they make some opening remarks, everyone will have an opportunity to ask questions. And I have this cool cordless mic. I'd like to thank our sound system guy over here, Matt Taylor, who is providing our sound equipment. And I will tell you that Jam is here doing a video recording, and we are tracking that. We'll be able to broadcast this event tonight, so hopefully spread some more information out to the general public. So we're very excited about that. I do have a cool little cheat sheet here to make sure I get everything. We want to thank the Plainfield Democratic Committee for hosting this event, and Sue Williams. Sue, say hello to everybody. Thank you very much. I'd like to thank my cousin and my aunt over here. It was Annie Davidson and Helen Davidson. Right here, we're doing the music. How about a round of applause for them? It's fun to do an event like this and look out and see family members sprinkled in here. So that's really cool. I hope everyone else is appreciative of that. Want to just quickly point out, some of you, I'm sure, have seen this a million times, but maybe a few people are not quite as familiar with this beautiful, historic theater backdrop designed by the famous artist Maxfield Parrish. So how about a round of applause for the beautiful backdrop? It's been meticulously restored by a wonderful committee here in town with support of the townspeople through their taxes. And so we're very proud of this building, proud of this town. We want to welcome you to Plainfield. I've lived here my whole life, and I'm very proud to be before you tonight, helping to get a lot of really important information out. We're going to get right into introducing your panel for you today. I'm going to quickly go through each of them, three of them, and introduce them, and then we're going to start, I think, with Matt, or starting on the other end, and we're coming towards me, and we'll recognize each of them for a quick sort of, you know what you're doing, the sort of summary of the situation, and then we'll have obviously plenty of opportunity. I'm going to come down the steps and actually come out to see you, and hopefully can get some good questions and comments and opinions and so forth, and just have a really lively discussion, which I think is very merited to do that now in the situation that we're in. So, without further ado, I'm going to start out with our panelists all the way down on the end. I'd like to welcome Deborah Fournier. She is going to highlight some of the changes and cuts to Medicaid and the Affordable Care Act and Medicare at the state and federal levels. Deborah is the Director of Health Law and Policy at the Institute for Health Policy and Practice at UNH. She has 20 years of health policy experience as a seasoned health policy lawyer, including serving as New Hampshire's Medicaid Director under just past Governor Sununu. So, Deborah, you're up, and I see you brought technology, which we're all very impressed with because it seems to be working. So,
all right, yay!
Enjoy.
Thanks everybody for having me. I'm Deb Fournier. If you call me Deborah, I will feel like I am either in trouble or in a courtroom. So please know, Deb it is. So it's my job to it is my job to set the stage and give a very high level select overview of the reconciliation law, otherwise known as OPA. So that's what I'm going to attempt to do. I don't mind if people ask questions in the middle, but you're going to get a lot of nerdy detail from me, and then you're going to get like the really interesting local, what does that mean for us, from the commissioner and Matthew, who both, like Lori was commissioner, and Matthew was a senator at one point, so I'm mixing my titles here, because I'm like, do I call them by their honorifics or not? Okay, so the reconciliation law, otherwise known as OBA, is primarily a tax law, and it extends, its main purpose is to extend 2017 tax reductions that were temporary and make them permanent. And the value of those tax cuts is $5.3 trillion. Another component of this is that there was an increase in spending for defense and immigration enforcement, and there are some eliminations of some energy initiatives and some changes to higher education funding. I am not an expert in those first four categories. I can make my way around Medicaid, and I can sort of make my way around SNAP, which is food stamps, supplemental nutritional assistance programs. The reductions to Medicaid for the entire country nationally total nearly $1 trillion. It's $990 billion over the 10-year forecast for the statute. The reductions for SNAP is roughly about 180 billion, which is about 20% of its typical budget, or spend, I should say. When we talk about health access, there are reductions in spending to Medicare, and there are reductions in spending to Medicaid. Most of the reductions in spending to Medicare make it harder for very low-income Medicare enrollees to access this cool program called Medicare Savings, which helps them pay their premiums and their cost sharing for their Medicare benefits. Those cuts also eliminate coverage for people who are lawful immigrants who have been eligible to receive Medicare benefits. And there are some general projections from the Congressional Budget Office which suggest that the deficit that the bill creates could put as much pressure as $490 billion worth of financial pressure on Medicare that would have to be cut in the intervening years between 2027 and 2034. And then in Medicaid, there are similar approaches to how the funding is reduced. The reductions in funding for Medicaid are primarily through frustrating enrollment by imposing work requirements, by imposing more frequent eligibility checks, for imposing additional cost sharing on the participants. It ends Medicaid coverage for many legally present immigrant populations. And then it really compromises, especially after 27 and 28, state financing options and provider payments. So that's a lot of information. SNAP gets reduced by 20%. Suffice it to say, the feds used to pay for all of it. Now the state is going to have to pay more, and for New Hampshire, it's very likely that it will be about $8 million to cover SNAP through 2028. And SNAP already has a work requirement. There is an addition to the existing work requirement, so that applies to more people. And there's now an ability to basically disenroll people if they have 3 different months in a 3-year term of not having the appropriate paperwork on file, which is considered non-compliance. And the estimates I've seen are that about roughly 4,000 people will be impacted by the new work requirement, the expanded work requirement for SNAP, which similarly will frustrate enrollment in SNAP. Do we need to do the basics of Medicaid? People know why people are so worked up about Medicaid, the cuts to Medicaid, $1 trillion in Medicaid. Do it?
Yes.
Okay. So we have public health insurance programs in the United States. Medicare, that is not this one, Medicaid. Medicaid is a publicly funded health insurance program, generally for low-income people. It was created in 1965, the same year that Medicare was created. And here's the deal. There are some big federal requirements for how the program has to be run. But it's elective. Not every state has to have, no state has to have a Medicaid program. If a state chooses to have a Medicaid program, it has to follow the federal requirements. In exchange for following the federal requirements, the federal government always pays a fixed percentage of the cost, no matter what happens, no matter if there's an AIDS crisis and a ton of people get too sick to go to work, no matter if there's a great recession and people lose their jobs, and which is our primary way of providing people health insurance in the United States, or there's a global pandemic. So the federal government always pays a fixed percentage of the cost, and that fixed percentage is never less than 50%. And in some instances, it's far higher. For some populations of people that the program covers, it's at this date currently 90%, 90. So that fixed percentage, you'll hear that a lot in policy conversations, is called FMAP, the Federal Medical Assistance Percentage, or FFP, Federal Financial Participation. It is mandatory spending. It is not part of the annual congressional budget because it is in federal statute and it's an entitlement. If someone is found eligible for Medicaid, they have to be provided Medicaid services. Congress can't stop those dollars from leaving, and neither can the state house, right? So the only mechanism that they have for essentially curtailing Medicaid spend is frustrating enrollment. And one of the features of Medicaid is that for standard Medicaid, you can't cap enrollment. If you need it, you get it. Okay, so public health insurance program for low-income people. Big federal requirements, but it's administered at the state level. If you play by the Fed's rules, they always pay at least half, and sometimes much, much more. Okay, so this is a pie chart of our Medicaid program in New Hampshire right now. And these are done by me lumping together some general eligibility groups. So the two biggest slices of the pie are low-income kids at 46% of our 184,000 people in New Hampshire who get Medicaid, and another 58,000. The second runner-up is 58,000 adults who are called our expansion adults. You'll see that about 12-13% are older folks and people with disabilities, and then there's about 8% that are pregnant women, former foster care kids, other non-disabled adults, and then some kids who have really, really deep needs. Their disabilities are profound enough that they qualify for in-home services. Okay, so our single largest eligibility category is children. And our second largest eligibility category are these expansion adults. So just to walk us down a little bit of history lesson, historically, Medicaid provided coverage to these four groups of people. In 1965, can you think about what all these people had in common with respect to employment? They didn't, right? Or they weren't expected to. Culturally, they didn't work or they weren't expected to work. Or in some cases, we still to this day do have child labor laws on the books, right? Kids weren't allowed to work. So there was no way to, and employment is the primary way that we connect people to health insurance historically, traditionally in the United States. So there was no other, if there was not a breadwinner in the house, or if there was not an employed person in the house, there was a program designed to connect them to health insurance. Okay? So typically in Medicaid's history, these are the groups of people who have been covered by Medicaid. Infants and kids, expectant moms, older adults, people 65 and older, and people with disabilities. So what low-income person, so you had to be low income and generally in one of these categories. So what low-income person is not in one of those buckets that you can think of? Right. 19 to 64, low income. Right? So that's the expansion adults. That's the people in the light blue pie slice. Spoiler alert, most of the enrollment frustration initiatives fall on them. The vast majority. Okay? So that's sort of a silver lining, I think. We don't need to talk about that. Okay, so in every county in New Hampshire, except for Rockingham County, 10% of the population, at least 10% of the population is covered by Medicaid. Every single county. Okay, and in some counties it's more than that. And New Hampshire in total covers about 13% of the population through its Medicaid program, which is a relatively low percentage compared to the rest of the states in the union, but is not the lowest. I think I have on this, North Dakota and Utah have a smaller percentage of their population that they cover through their Medicaid program. Okay, so back to what I was saying before. So the reconciliation law reduces Medicaid spending by frustrating enrollment, it imposes work requirements, more frequent eligibility checks, it increases cost sharing, and it actually outright ends Medicaid coverage for many lawfully present immigrants. So that's more at the member level. Then there's the financing level, where the federal government has told states that it's going to limit something that they call provider taxes for generating the non-federal share. Remember I talked about, the feds always pay 50% of the cost, right? The FMAP is 50%. There's a federal share and there's a non-federal share. And there's all these rules about the ways that it's okay to raise revenue for the non-federal share, okay? So a way that we've used often in New Hampshire is provider taxes. So there's going to be limitations on what percentage point a state can use to generate the non-federal share from provider taxes. The other way that Medicaid spending is reduced is by really limiting payments to providers, and this is in two really important ways. One is to limit something called retroactive coverage, and the other is to limit state-directed payments. So retroactive coverage is this principle that if someone becomes eligible for Medicaid, a provider can bill Medicaid 3 months prior to when they became eligible for any care that they had provided them, so that the provider could be made whole for care that they had, uncompensated care that they had provided, right? And to encourage and incentivize providers to sort of usher people into the program. The state-directed payments to providers are payments that a state Medicaid program can make to a particular group of providers or a particular type of provider if it wants to incentivize a certain kind of behavior. And there's all kinds of rules about what kind of payments you can make and when, but these state-directed payments have been allowable. And now there are going to be limits within which a state has to make its state-directed payments. So, for example, sometimes you make directed payments from a Medicaid program to a provider type when you have an opioid crisis and you want to encourage the opening of recovery centers or of more opioid use disorder treatment. And you want to smooth the pathway for providers to expand their business in that business line, or you want to highlight something that really is a huge need that needs to be addressed and isn't otherwise being reimbursed. So all of those avenues are being slowly cramped. I think I'm just gonna, I have slides that go into all the details about this. I'm not sure that's what you guys need, though, like at what year, what percentage point goes down to what. But we can if you want, but I don't, there is a little good news. There are some bright spots. One is called the Rural Health Transformation Fund. It's $50 billion that's been appropriated. Every state, if every state applies and their application is approved, the first half of that $50 billion will be distributed evenly across all 50 states. So, in other words, every state, if they apply and their application is approved, will get $100 million every year for 5 years. And there are, the second half of that funding, the funding will be distributed based on the relative rurality of the state and on the scores of the application and the certain components that the state puts forward as being their strengths or their needs. So the guidance came out last week, Monday. It's due November 5th to the feds. And then federal HHS has to approve that by the end of December of this year. Nobody's guaranteed an approved application. But if your application is approved, then you'll at least get, or Matthew and I were just talking about this. If the statute's followed, 25 billion evenly by 50 states is 500 million, right? But who knows whose application is going to get approved and for how much. One of the trickiest things about this money is that it all has to be spent before the next fiscal year, when the next tranche of dollars comes in. Not encumbered, not obligated, which are state bureaucrat words for we issued a contract and we're going to go with them, but like the money has to actually have gone out the door. No, can't be used for infrastructure. I mean, there's a ton of what it can't be used for. It can't be used for the state share, for Medicaid. Yeah, there's a lot of fine print that we're not going to bore you with, and the funds have to be used for 3 of the following activities. Oh, I wrote in my notes all the unallowable costs. So it's stuff that everybody can agree on, right? Providing, new evidence-based intervention to improve public health, payments for healthcare providers, payments for technology, training, retaining clinical workforce in rural areas. For every one of those things that says you can pay the money, you can spend the money this way, there are many, many more conditions about what are unallowable costs, some of which are also relevant to which providers you can pay and what you can pay them for. Like if they're already being reimbursed or they can be reimbursed for it by insurance, you can't use the money to pay them for that. You have to find something else to pay them for. This is the timeline of when these provisions are going to hit. The purple is OPA, is the reconciliation law, and the green are provisions that impact Medicaid that were in our latest state budget, what was just enacted at the end of the fiscal year. So I'm going to say thank you and pass the microphone off to my colleague.
Yes, thank you so much, Deborah. There's a lot to this, and you're getting information from people that know what they're talking about here, so this is great. I want to move on, and I apologize. I said I was going to introduce all 3 of them, and then I passed it right over to her, so I guess we're going one at a time here to start. Next up, we're going to hear from Lori Shibinette, who will cover mental health effects and the effects on addiction programs in the state because of the recently passed legislation that we're talking about tonight. Lori is the CEO of West Central Behavioral. She served as the CEO of New Hampshire Hospital, the state's psychiatric hospital. Lori is also was also the New Hampshire Commissioner of the Department of Health and Human Services during the pandemic. So we'll pass it over to you for some opening remarks. Thank you.
Come on. Great. Well, thank you so much for having me. As was said, I am the CEO of West Central Behavioral Health. It is the community mental health center here in the Upper Valley. We serve clients everywhere from Lebanon down to Claremont and even south of Claremont. We have 3 locations, Newport, Lebanon, and Claremont. A lot of what Deb talked about impacts our clients in multiple ways. As you can imagine, we serve clients that have serious mental illness and severe and persistent mental illness. Those clients are also on SNAP or food stamps. Many are also dual eligible and on Medicare. So it hits them in more than one way, more than just Medicaid. We serve thousands of adults, children. We're in all the schools, Lebanon, Claremont, Newport schools. We have crisis services, so we have a mobile crisis team that goes out. You call 988 or our rapid response number, and we send a team to your home to help manage a mental health crisis that you're having in your home, or we can even meet you at a park or a Dunkin' Donuts. Most of our care is provided in the community. Our goal was not just to treat our clients with mental illness for their illness, but our goal was also to help our clients build a life outside of their illness. What we know are that people that have hobbies and purpose and families and natural supports, all of those folks, they have more happiness, more relief of mental health systems when they have those things that surround them. So we do all of that. This new bill is very scary for our clients. When we talk about frustrating the group of people so that it makes it harder to get on Medicaid, it makes it harder to stay on Medicaid, and it makes it really easy to kick people off of Medicaid, those are our clients that we're talking about. These are the people that have serious mental illness. And we're not talking about just kids or just adults. We're talking about kids from young toddlers right through the school age that we treat. So everybody's impacted. It's going to impact agencies like West Central Behavioral Health more than average because we're considered to be a safety net in our community, which means we take care of the sickest of the sick. We take care of the poorest of the poor, the most vulnerable, and the homeless. So those are our clients. If we're treating someone that is actively psychotic, actively having a breakdown, we're not going to say, sorry, you lost your Medicaid, we're going to stop treatment now. Agencies like West Central, and there's 10 community mental health centers across the state, we keep on treating those clients and help them get back on Medicaid, but we don't get paid for all of the services we provide while we're trying to get them back on Medicaid. So we're a $10 million agency is our gross revenues in a year. In 2024, we provided $611,000 of uncompensated care. That's a huge amount of money for a small agency like West Central Behavioral Health. So when you make it harder for someone to get Medicaid eligibility, easier to kick them off, more difficult to stay on, we're not going to stop providing services. It's going to hit us differently than it's going to hit maybe a for-profit agency that can just say, I'm sorry, your insurance doesn't cover this, we can't provide services. We need to provide services. So where it's going to impact is that we are not going to get paid for our services, and we are going to have to find different revenue sources because our clients can't pay for services. So you'll see us out. Deb Herndon is in the audience somewhere. Deb, raise your hand. Deb is our development director. We live on a shoestring budget, and Deb is responsible for raising charity. She goes around and she begs for money and holds fundraisers, and that's how we provide care to our clients when they get kicked off Medicaid. We are building a new building in Claremont, and we're able to do that because we became a certified community behavioral health center just this past July 1st. But it's so essential to have access to care in cities like Claremont, where people can walk into open access and get mental health treatment when they need it. Not on a wait list, not at an appointment 3 months from now, but today. And anybody that's had a family member that has had a mental illness or suffered from a mental health system, you know that when they decide that they need help, they need it today. Not a week from now, not 2 weeks from now, not 3 months from now. They finally decided to get help. They need it today. And that's the level of service that we need to provide in our communities. And to do that, it costs money. And because we rely, 90% of the people we serve at West Central are on Medicaid. 90%. It is our main revenue source. Because of these bills, we are going to have to raise additional funds through other mechanisms in our communities to be able to provide the same level of service that we're providing today. I'm going to stop there so that you can give Matt a chance to talk.
Thank you so much. So we're going to move on to Matthew Houde, who's going to focus on the effects of these changes and cuts on New Hampshire hospitals and on the individual healthcare access and costs. Matt is the System VP for Government Relations at Dartmouth Health, receiving his Master's of Healthcare Delivery Science and a JD. He was also our former state representative and our state senator. Welcome, Matt.
Thank you. Thank you, Ron. I'm going to do, it's a Plainfield Democratic event, correct, sponsored event, and what I'm shocked and that Rob did not do this. I'm going to do it even though there's a huge risk typically at these events where if you start to recognize your elected officials, everyone in the room will stand up, but I'm going to do that anyway. So I'm going to recognize, and the second risk is that you miss somebody. So if I do that ahead of time, I'm apologizing ahead of time. I see our executive counselor, Karen Leo Hill. Karen. I see my predecessor and successor for District 5 State Senate, Peter Burling and Sue Brentis. I see my rep, Bill Palmer. And who am I forgetting?
Damon.
Representative?
Hope Damon.
Thank you for joining us, Representative Damon. Nice to see you. And we don't have just, did I miss somebody else? Oh, former. Hi, Representative, how are you?
If you start introducing the former, it is everyone.
But we not only have one former commissioner, we have another former commissioner in the audience, Steve Taylor. Steve, if you want to raise your hand there for everyone to see. All right, fabulous. I'm going to move beyond that before I get myself in more trouble. Thank you for coming tonight. As it is a Plainfield Democratic sponsored event, I'm going to use the disclaimer. I serve as the Vice President of Government Relations at Dartmouth Health. Dartmouth Health is a 501c3 nonprofit organization. We are a nonpartisan organization, and so I need to be clear about that. But I can tell you when policy is bad, right? I'm not going to tell you that the people who passed it is bad, but I'll tell you that the policy itself is bad. And I think you've heard a little bit about why that's the case tonight. So I won't cover, I think Deb is being modest in terms of her knowledge of Medicaid, clearly, right? It's encyclopedic. Whenever I have a question about Medicaid, I will call Deb and say, please walk me through this as if I'm in kindergarten, and she has done that many times, so thank you for that. And I don't know that I've had the opportunity to thank the former commissioner for her navigation through the pandemic for the state of New Hampshire, so I wanted to think about that. Not a small task, certainly. Okay. The buckets, right? What are the two big buckets that Deb talked about? And I realized my job here is to talk about the impacts of the OBBBA on hospitals, cost, and access. So I'm wearing a hospital lens, right? I work for Dartmouth Health, which is a umbrella organization that has several hospitals within it. You're all familiar with them. Mary Hitchcock Memorial Hospital, of course, just across the river, Mount Scottney, Valley Regional recently, APD, New London, et cetera, Cheshire, and the Visiting Nurse and Hospice Association. We're a pretty big organization that serves this. We're the largest provider of healthcare for the state of New Hampshire and the second largest for the state of Vermont. So I would say, I don't want to do an insurance 101, but I want to talk about it a little bit just to give you the context of this. So there are commercial payers, Blue Cross Blue Shield, United Healthcare, Cigna, those types of providers. There are public payers, Medicare, for those over 65, Medicaid for vulnerable populations and income-eligible folks. I'm missing another thing, VA coverage, TRICARE for veterans populations. And then there's a group of uninsured. And New Hampshire is pretty good in terms of its uninsured rate, right? We're just under 5% uninsured. Comparatively to other states, that's a low number, but there are still people who are uninsured, so that falls into that category. I think I started to say, Dartmouth provides its aggregate Medicaid population proportion is 15%. So 15% of the patients that we see from New Hampshire and Vermont are the Medicaid population. That contrasts to the 90% that Lori talked about with respect to West Central. That's an important thing to keep in mind because I'm going to talk a little bit now about the macroeconomics of this, right? What can a state do, I've talked about this, to address the squeeze on the front end in terms of hitting eligibility for beneficiaries and the back end in terms of limiting program funding? They can really only do two things as far as I know. My colleagues will correct me if I'm wrong. One is they can reduce the amount that they pay providers for the care that they provide, or they can kick beneficiaries off the rolls and categories. I think that's all they can do. So that's limited. And the state doesn't want to kick beneficiaries off the rolls, and so what they'll do is they'll reduce the rates that they pay to providers. The problem is New Hampshire is notoriously one of the lowest Medicaid reimbursers in the country. Dartmouth Health is 40 cents on the dollar. So over the last several years, each year, Dartmouth has provided, let's call it $300 million in cost of care for Medicaid beneficiaries, for which we've received $100 million. So what's the delta? The delta is $200 million. What happens when that happens? What are providers supposed to do in that situation? I don't want to go into financing. There is some help from the federal government for uncompensated care, right, and undercompensated care. So we get some relief to mitigate the amount of uncompensated care we provide. That $200 million underpayment from Medicaid plus the people for whom we provide charity care, which is either free or reduced based upon their income levels. Healthcare providers have, I think, three options too in terms of what they can do when they're faced with that type of hole. One is to cost shift, which is to charge those commercial payers, this is why I talked about insurance at the beginning, more for services than they get under Medicaid or Medicare. So your Cigna plan, all of a sudden, we're going to negotiate with Cigna, we're going to try and negotiate with Cigna for more money for the same services that we get paid less money from a different payer on. That's one option. The other is you can reduce costs, right? So you can let people go, or you can stop providing services. I mean, so that's another option. No provider wants to do that. And so the third option is you could absorb those costs to some degree. And then there's a question of how much can you absorb those costs. Usually it's some of all three, right? You're doing some of all three of those cost-saving, revenue-generating, absorption philosophies. And I believe that Dartmouth Health, it's huge, right? It's big. It has lots of members in it. We're going to survive the cut because you're going to go from getting paid 40 cents on the dollar to getting paid 35 cents on the dollar in Medicaid in New Hampshire. West Central Behavioral Health is in a different boat, right? Because they have 90% of the people who come in their doors receive Medicaid. And so what do they, you were incredibly optimistic with respect to we're going to raise funds, alternative funds, to plug those holes. That is one of the choices, and maybe the only choice that they have. Otherwise, you limit services. Hospitals, too, provide care to all comers, right? There's a federal law that requires hospitals to accept everybody who comes to the emergency department. We don't want to turn people away. But what does this do to access? It constricts access, right? Because you're either, say you're waiting, I don't know, a month for a primary care visit today. And then Dartmouth has to make a decision about, do we expand our primary care population, our provider base, or not? Well, we can't right now because we're going to take a hit, and so you're going to wait 2 months for a primary care visit, right? Because you're not meeting the demand because you have fewer resources to do so. Or someone doesn't answer the phone when you call them to get your medical record as quickly as you'd like, or don't call you back as quickly as you'd like. None of those things are good options, but it's part of how you navigate being squeezed by the federal government on the front end and the back end. I'm going to look at my notes now to see if I want to make any other comments before opening up for Q&A, so excuse me for 1 second. I covered it all. No, there was one thing I didn't cover. Lori's population, kind of, we talked about the front end, right? We talked about the access to care and the constriction of the doors being open to that. A huge concern for hospitals and Dartmouth in particular is the inability to get people out. Because who else is heavily relying on Medicaid reimbursement? Nursing homes, long-term care facilities, et cetera. So they have a huge task to get people to staff the beds that are available. So you have fewer beds to send people to in the communities when they no longer need the acute level of care that Dartmouth provides. Well, that's unfortunate for those people. They have a roof over their heads, and Dartmouth isn't getting paid for that, but that's not the issue. The issue is that when the emergency happens, that patient can't get into a bed because those beds are occupied, and at the peak, up to 20% of Dartmouth Health beds were occupied by people who no longer needed that level of care, but there wasn't a place in the community. Now that's at the peak, it's closer to 10% on average typically, but you're still talking 10% of 440, 80 beds, right? Like that's a huge number. So people end up in Albany, Massachusetts, elsewhere because they can't get care locally because of the constriction that's taking place on the system. So that's really the last point that I wanted to make about what happens when the government downshifts costs to the providers and state.
Thank you, Matt. Excellent opening remarks from all of you. We're peeling back the onion here, and we're really diving in deep. I would like to just quickly start out the questions, and I'm going to come down to the audience. And when I do that, you can ask questions, and I'll come bring the mic over, just like, remember that show Donahue? You guys remember that a long time ago? That's what I'm going to copy tonight. Real quick, for Matt, we'll start out with you. You've talked about what's going to happen with Dartmouth Health, which, as you said, was several hospitals, and obviously I think there's probably going to be strength from a big organization like yours. Talk to us about the little rural hospitals sprinkled around up in the North Country or elsewhere in the New England states.
So Rob read my notes, the ones that I didn't read, because in addition to the community mental health centers throughout the state who are heavily reliant upon Medicaid for coverage for its patient population, hospitals in different parts of the state have different proportions of Medicaid caseloads, right? So Dr. Palmer can tell us what it is at Mount or Valley, let's call it at Valley Regional in Claremont, 30. I mean, I'm making this up, but let's call it 30. Dartmouth, as I said, has a combined 15, so it's lower. Many of the hospitals in the North Country have a much higher percentage. Actually, the commissioner will know this. I don't know why I'm looking anywhere else. Former commissioner would know this. They have a higher percentage of Medicaid as part of their payer mix, if you will. And so they have a bigger financial hit and less of an ability to spread those costs around to other types of insurers, if that makes sense.
Thanks, Matt. Any of the other panelists want to respond to that?
I would just like to point out that it is the safety net providers in all the different areas of healthcare that are going to be hit the most. I talk a lot about, mental health, because that's my my area. But Matt's right. Your critical access hospitals that rely on Medicaid, your disability population that relies on a disability waiver, any of the safety net providers and the clients that are in a safety net program, those are the ones that are going to be most impacted by these changes.
Deborah, you got anything?
Sorry, I was sitting here imagining about, we've only talked about Medicaid. We haven't talked about the fact that both Matt and Lori said these changes to Medicaid will make it harder for people to get onto Medicaid, stay on Medicaid, and for providers to be paid by Medicaid. In addition to that, the work requirement for Medicaid, if a person gets kicked off of Medicaid or fails to be eligible for Medicaid because of the work requirement, they will then also be made ineligible to get financial help on the marketplace to purchase the product themselves. And the financial help that's available on the marketplace has been extra generous the last 3 years. That extra generosity is ending unless, has Congress done something that I don't know about?
Not recently.
Okay, so that extra help is also ending at the end of this calendar year, which means there could be a lot more uninsured people next year, because without the financial help and without being able to access some of it because they got kicked off of Medicaid for work requirements, or the financial help that is available isn't deep enough to make it worth their while, people will just go without. And there's 60,000 people on healthcare.gov who get their insurance from healthcare.gov in New Hampshire, and roughly 70% of them got financial help in the last year, right? So it's the overwhelming majority of folks who purchase on the individual market who get financial help. So I was off imagining, like, it's not just Medicaid, although Medicaid is certainly going to impact the providers sitting up here, but it's also going to be, I think, an additional amount of people who will be uninsured or will be encouraged to be uninsured, and will add to both of their uncompensated care caseloads.
And I'd just say, people that get kicked off Medicaid because they're not meeting the work requirement, it's not because they're not working, or it's not because they don't have a waiver. It's because they're not able to file the paperwork and meet the administrative burden for the eligibility. That is what we find over and over again, even before the work requirement, just regular Medicaid recertification. The majority of people get kicked off Medicaid because the paperwork wasn't filed in time or get lost somewhere. And so when your clients are homeless, living in a car, couch surfing, there's a really good chance that they're going to miss the paperwork that they have to submit to get the waiver they need or to prove that they are working, and they're going to get kicked off, and it's going to take months to get them back on the program. And all of those months, we will continue to treat and not get paid for it.
The retroactive is probably just
Okay, we've got a question from the audience. First one. Go ahead.
So just to clarify, so Deb, you said that bank of money that's for the rural hospitals, it would be evenly split if the first set of criteria gets met in all 50 states. It would be evenly split no matter what the population of the state is.
Okay, yeah, Rural Health Transformation Fund, the application, the state has to apply. That's the only recipient, the only possible recipient for those funds. The state has to apply. If every state applies and every state's application were approved, every state would receive $100 million, allegedly, every year for 5 years. And then the second half of dollars would be distributed basically with a more weighted approach. How rural is the state? Does it have a certificate of need board? How much uncompensated care does it provide, et cetera, et cetera?
The only thing that I would add to that is, so it's not trivial, right? It's $50 billion allocated for addressing challenges in rural healthcare, but there's a $1 trillion cut to Medicaid over 10 years. So it doesn't fill the hole that's created over that period of time.
Yeah, thank you. Deborah, does New Hampshire have the bandwidth to be able to take our share? I mean, there's obviously going to be a huge administrative.
So I think New Hampshire is I know New Hampshire is planning to apply and will apply. The trick of these funds is that they have to be spent before the next tranche of dollars come. Not obligated, not encumbered, it's out. And that will be a challenge for New Hampshire, is moving the money quickly enough.
We've talked about cuts to Medicaid, but my understanding is there are also cuts to Medicare. Can you talk about that?
I know a little bit about that. This is what I understand about the Medicare changes. Is that there were a couple of rules that were supposed to go into effect at the federal level, and the law essentially prohibits them from being implemented. And those two rules were going to make it easier for very low-income Medicare beneficiaries to enroll in the Medicare savings plan. So it would be harder for people who have trouble paying their Medicare premiums and cost sharing to get additional financial help to do that. It also eliminates Medicare eligibility for a number of immigrant populations, and then it will just generally put financial pressure on Medicare to the tune of about $500 billion over the next 10 years.
We've got a question here in the back.
Hi. So this is mostly maybe directed at Matt. You said that when hospitals are squeezed on these revenue centers, they will then get the revenue elsewhere, one being charging private insurers more. So if you fall into none of those categories and you have employee-sponsored health insurance, can we all anticipate that our premiums that we pay to our employers will increase?
So I want to acknowledge that there are a number of things that go into rate increases. And so it could be things like the cost of prescription drugs, right? It could be tariffs that are put on supply chain items. There's a number of things that feed into rate increases. So the cost shift that I referenced is, I think I was trying to evidence that if hospitals are going to get paid, if providers are going to get paid less for providing a service through Medicaid, and they're going to pay even less tomorrow, then they're going to try to get more from the private carrier tomorrow as well. So to your point, yes, there will be pressure on rates to increase as a result of that. I just want to not paint the picture of hospitals as the sole driver of the increase in healthcare costs. One of the places where we're seeing this tension dramatically play out today is across the river in Vermont, where there's a regulatory body that is constricting growth for hospitals and carriers. You have a carrier that's financially on the verge of insolvency, and it's going to be fascinating to watch how that all plays out. And they have price caps in place on medication acquisition. So read the Valley News or Vermont Digger, right, in terms of see what it could look like as costs rise. New Hampshire has not seen the types of premium increases that Vermont has seen recently.
I think they are coming, though, and it's not just about this bill. Like, there are a number of factors, but next year's premium increases and the year after that, I think, are going to be eye-popping for a lot of people, regardless of whether it's employer-sponsored insurance or individual.
We've got a question right here in the middle.
Thank you. I wonder, I'm a primary care provider in the state of New Hampshire, and I wonder if there are projections about the effect on the workforce in primary care. I mean, it matters in any kind of healthcare provider, but we know that primary care, access to primary care is a major driver of reducing healthcare costs. So is there any projection? I mean, it looks to me like there's going to be a lot of people that leave the workforce because of this.
So I'll take this. It's one of the reasons why they created the Rural Transformation Grant, right? So they are trying to front load some of these issues around, specifically around workforce and technology are the two big areas. So what the purpose of the Rural Transformation Grant is to invest in primary care workforce, in healthcare workforce overall, and to build it up before it gets decimated from Medicaid, which is a terrible way to put it, but that's basically what they're doing. They're front-loading it so we can build up our systems to handle the impact of what's going to happen with this bill. And primary care is a major focus of that.
Question right here in the middle.
I'd like the three of you to turn your attention to not the issue of what's about to happen or what is happening, but also what we can do about it. I promise myself to turn the TV off every morning because I can only take about 5 minutes. The issue of impact is clear. The question is, what are the resources we're willing to bring to bear to push back against this? And as the front line, and I'm sorry to do this to you, but you are kind of the front line, how do you see us responding? What's the most efficacious way?
So I'll try to tackle that one first, I think. I meant to say in my closing remarks, Peter, that I didn't want to end with an ugh, right? Because it just feels ugh. This all feels like heavy and hard and scary. We've seen and hopeless. But I would say two things in response to that. One is the relief funds. Let's assume that the state of New Hampshire is working really hard to put together a comprehensive application that's going to at least hopefully cushion the blow for rural populations. I'm willing to say that, their stakeholder engagement, really thoughtful about this. The other thing is, we've seen changes made in Congress that get reversed before they're actually fully implemented. And so there is, I'll be optimistic and hopeful that there is a potential, probably not in 3 years, but there's potential that when the cliff comes, when all of these pieces come and are going to start to really crush state programs and people's lives, that cooler heads will prevail and will mitigate the damage a little bit. That's what I'm hopeful about. What are we doing about that? We're trying to position the health system to make sure that we can continue to provide care for everybody that needs it. So that's in my professional capacity, that's what I'm working to do. And then I guess I'll stop there because there's a political capacity here too. I don't know that anyone up here is going to answer that question, but that's another component. And then I'll see if my colleagues have some of that.
Lori, want to take a?
Sure. From the mental health space, I think we're looking at survival over the next several years. That's our main focus, is hoping that the rural transformation money is going to put us in a place that we are going to be able to weather the storm to get to the other side. We are optimistic, like Matt said, that there will be more healthcare friendly policy in the future. So we are trying to weather the storm and survive. But the two things that focus on mental health parity. So Matt talked a lot about the fact that, Dartmouth can negotiate with the commercial payers to pay them more, to subsidize where they get paid less. Commercial payers pay us less than Medicaid, in that they don't cover most of our services. So minimum mental health parity law that requires all payers to pay for a minimum amount of mental health care, I think is required. And then the other thing I think we really need to focus on is telling stories, because for people in elected positions, when you put a face in humanity with the programs that are being cut, it makes a huge difference. So when you see a person in your community impacted, tell the story with a name, with a face, with the impact, because that's what makes a difference.
And Deborah. Finally to you.
You can tell she's a former commissioner. So what I'm doing is coming to events like this and showing people what's under the hood, because the things that we talked about aren't going to happen immediately, but all those changes, frustrating enrollment and limiting provider payment and limiting ways for the state to generate the non-federal share, ultimately it gives the state fewer and fewer options for how to finance the program, and there's 185,000 people who rely on it, and most of them are kids, and another good component of them are people with disabilities and senior citizens. So it is really important to talk about the lasting impact of this statute, and to not drop it, but to keep thinking about it, because eventually, when there are fewer ways for the state to generate the state share, the non-federal share, and when there are fewer ways to pay providers, that's when states start making really hard decisions. Like, for example, I think I didn't cover this bullet point. In every Medicaid program, there's mandatory populations and optional populations, and mandatory services and optional services. The mandatory populations and the mandatory services, you have to play ball there. If you don't cover those, you don't get the federal money. You don't get the federal match. You can choose then to put optional services and optional people on your program, and you still get the federal match. Since this law was created in 1965, guess what an optional service is? Prescription drugs are optional. You don't have to cover them to have a compliant Medicaid program. Mental health and substance use disorder services are optional services. They are not required. You can still draw down federal match and not cover them and not offer them. So what I would say to you is, there are things coming, choices that the state will have to make, and it will be forced to confront ideas like, can you provide health insurance in which prescription drugs are not covered? And what is the result of that? So I think the eventual positive policy and the eventual congressional action we all hope for. But in the meantime, these people don't have health insurance unless they get it through Medicaid. And those kids and the people with disabilities and the senior citizens, they don't have another option. The expansion adults, most of them are working, because you can work a minimum wage job in New Hampshire, full-time, 52 weeks a year, and make less than the federal poverty limit, which means that you are working full-time and you qualify for Medicaid at the same time. Low incomes are not necessarily about people not being employed, and work requirements have not been shown to improve employment. They have been shown to frustrate enrollment. So, I would ask you just to remember our conversation tonight as a way to move forward.
As executive counselor, one of the things I'm doing is working hard to make sure we put together the most competitive application that we can for the rural health transformation program, because the stakes are just so high. So just a couple of weeks ago, the governor and the current commissioner of Health and Human Services launched the program. Councilor Joe Kenny, who represents the North Country and then the eastern part of New Hampshire, he and I have the two most rural districts, and so we were invited to be part of that launch. Matthew was there as well, and it was a good stakeholder engagement. But I'll tell you, at the executive council table, the Republicans there are actually deliberately trying to frustrate the efforts of the department to put together a competitive application. The commissioner brought forward a contract, $150,000 of federal funds to hire a consultant. You see, we have 2 months to put this together. Not very much time to apply for $100 million for next, that we need desperately. And the boys, I call them the boys on the executive council, there are 3 of them, and there are 2 women. I'm the only Democrat, but there is one other woman, Janet Stevens, and a lot of the votes have been 3-2. And the boys voted down that contract to hire a consultant who the commissioner said was really needed to help us put together a competitive application. Just yesterday, then, they also tried, one of the things we've got going for us is that New Hampshire is on track to be the first state in the nation with 100% broadband coverage, thanks to $100 million of ARPA funds that we've put to use for that. I think Plainfield and Cornish have been working on receiving funds to build out their broadband as part of that. And that is a really potentially very strong component of our application. At the council meeting yesterday, John Stephen made a motion to table some funds that are necessary to complete that project. And so I made the case, and fortunately that motion, that the stakes were too high, that we really needed to continue the rollout of the infrastructure of the internet, broadband infrastructure to help us be competitive. And fortunately, we were able to beat that tabling motion. Joe Kenny voted with me and Janet Stevens. But I'll tell you, good, Kenny voted against the $150,000 grant. So I'm just saying that I'm doing my best, and one of the things that's frustrating, I can say it because they don't want to be too partisan, but the Republicans are intentionally trying to frustrate our efforts to even apply for some of this money that is going to be really necessary. And so I think another piece that we need to do is hold them accountable and make sure that people understand what the Republicans are doing. They are deliberately cutting the budget and then deliberately making it harder, frustrating not just the people who are applying for Medicaid, but also frustrating the state's efforts to try and apply for some of these federal funds that will be available.
Guys, any of you want to respond at all to her, or we'll keep going? I've got a question right here.
So I'd like to bring it down a little further, to your clients. And I can't imagine, so I'm a single mom, I don't have a job, I'm on Medicaid, I don't have clothes for work, I don't have a car up here, I don't have daycare, right? Your work requirements, are those, I heard they're making them more frequent, right? Is it like when you're unemployed that they have to prove they applied for 3 jobs? And I can't even imagine every few months trying to find jobs that I would be qualified for. Can you just say what are the exact work requirements?
So the work requirements are not specified yet. What we know is that they'd be looking for 80 hours of whatever a qualifying activity is. And that might be work, that might be looking for work, that might be school, that might be volunteering, okay? There are going to be exemptions for people based on, there might be a really good reason the person isn't working, right? Like they're not well, or they're caretaking for someone else. I believe I saw in the statutory language that for people with children under the ages of 14 who are in the expansion population, that they would be exempt because they presumably have school-age children at home, right? The devil is going to be in the details. New Hampshire tried to implement a work requirement 6 years ago, 7 years ago, and 8 years ago, and spent a fair amount of money attempting to do it. But the requirements, the paperwork requirements, were so onerous and hard to explain and complex. As you said, people are just dealing with the daily fires. They didn't have the time or the bandwidth to put together what it was they needed to prove and to whom. And they thought, well, nobody's sick today in my house, so I'll worry about it later, right? I'll worry about it when someone's not well, and then we'll worry about getting health insurance. So so to answer your question, I'm sorry, I rambled. The details are not fully known yet. The guidance about work requirements is expected from the feds at the end of this year. The work requirement is supposed to go into effect at the end of next year. But they tend to be difficult to comply with. And in every system, there's going to be people who don't comply because they just don't comply. But our prior experience is that the reporting requirements were so detailed and so specific. It's almost an impossible program to effectively administer.
Which was their goal.
Okay, we're over here on the edge. Lee?
New Hampshire is one of the richest states in the richest country that has ever existed in the history of the world. And it is unbelievable that we are experiencing this continued cramping, reducing, and harming the most vulnerable populations in the state. And I understand that we invited, the Plainfield Democrats invited you here as a nonpartisan panel, and we appreciate your expertise. But honestly, it's impossible not to say, why does this country not have Medicare for all? We have the program. We understand how to do it. It's a political choice. Why do we have a minimum wage that's $7.25? It's a political choice. Why don't we have taxes that are according to people's income and ability to pay? It's a political choice. And I think it's time that we are open. And I was in the legislature for 8 years, and how often did I say, we need an income tax in New Hampshire? Not a lot. I can't think of a time I said that. But honest to God, I believe it. I've always believed it. But it's time. It's time for all of us to say the things that need to be said, to talk to our families and our friends. And then, of course, there's the New Hampshire way, which is West Central. Plead with people to contribute. Here in Plainfield, we have 100 families who aren't going to be in trouble in 2027 and 2030. They're going to be in trouble this winter because water rates are going up, electricity rates are going up, rents are going up, housing is more difficult, child care is the whole span. That's 100 families in our community, and we need to see their faces, and we need to step up and dig in. We have a shell fund at Plainfield at the town hall, and please do give this year and do give generously.
More questions? We're coming down the home stretch here. We got about 15 minutes more. We're going to try to be respectful of your time and wrap this up at 8:30, so let's get a few more questions.
Thanks, Rob. Hope Damon, State Rep for half of Sullivan County. Thank you to the panel. You guys are working so hard, and it is just such an untenable situation. I want to bring up one additional topic, and then I want to echo Lori about stories. So we've been talking about the federal cuts to Medicaid, and on the state level, the governor invented, I guess I'll say, the idea of Medicaid premiums. So now there are going to be any number of people who qualify for Medicaid but cannot afford the added premium, which in many cases is somewhere around $250 a month. If you qualify for Medicaid, you don't have $250 a month to sit around to pay your premium. So they're going to drop off the rolls. What is going to be available to those people who join the ranks of the uninsured? That's my question. And my echoing the stories is, all of us in this room are probably of like mind. We need to be telling the stories and sharing the urgent needs of people who are not able to be in this room. And we need to share them to the decision makers, which is not the Democratic Party right now. And we need to do it over and over and over again, not wait until campaign season, but be communicating to the Joe Kennys, for example, every single week. Tell the stories. Sooner or later, we have to crack open some level of compassion.
So, ironically enough, the federal law that was just passed prohibits the imposition of premiums on Medicaid members. Yeah, but it does, the increased cost sharing requires a $35 copayment for a variety of different services. but they exempt a number of services like primary care and behavioral health from that copay requirement. So the good news is the state won't be in compliance with federal law if it attempts to enact its the governor's proposal, as you were saying, for premiums. So a ray of hope, or a glimmer for not worrying about that particular issue.
The only other thing I'd add is we're having this conversation internally, and there's a full expectation that Dartmouth Health members won't collect copays or premiums from beneficiaries, and we're not going to make an effort to collect those. That just goes.
Matthew, what happens if you don't collect them? What happens to you guys if you don't collect those copayments?
Well, it increases the amount of uncompensated care you provide, but
right, it's effectively a rate cut. Like if the copayment is supposed to be collected at a point of service, and they're like, forget it, it's not worth it. That Deb doesn't have $25. She had to beg, borrow, and steal to get here today. Like we're not even going to bother trying to shake her down for $25.
That's exactly where the copays and what we call spend downs in mental health happens, which is the client's share of the expense. They show up at our reception desk because they had to take a bus because their car broke down and their kids need boots and backpacks and school supplies. And if they say, I don't have the $20, $25, $35 or whatever it is, I'm not going to tell them they can't have their appointment. So it becomes part of our uncompensated care. And that is a normal thing at West Central, day to day, every single day, today. Every day we are not collecting copays and deductibles because our clients can't afford it. In 2024, it was $611,000 of uncompensated care that we provided at West Central. Now that's not all copay and spend down, but it's a combination of copay, spend down, commercial insurers not paying.
But I'm just saying, what percent of people, just off the top of your head, no one's going to always do it, come in and can't do their copay? Like, is it 5%? Is it 15? Is it 30?
Oh no, it's well above 50.
Okay, we got a question here in the middle.
Thank you, Dave Trumbull. Thank you for your work. I have a question. It seems like healthy people are the greatest resource we have in this state. Can you, with your, just describe to us, if you have any numbers, if people were able to get the health care that they needed, the state would be more prosperous, we'd have a better economy. Kind of take us through the impacts of a lack of health care on the state and on people's ability to work.
Who wants it?
I think we can all touch different parts of that elephant. I don't know that any of us can answer all of it. So I will say that when New Hampshire expanded Medicaid the first go-around, you saw a dramatic reduction in the amount of uninsured people coming to the emergency department for care, right? Which means that they are going to their primary care provider, or they're coming to the ED and they have insurance. So that was a significant, measurable difference when people have coverage. And Lori may know the statistics better than I do, but one of the populations in the Medicaid expansion population or services that there was a dramatic increase in was mental health disorders and substance use disorder services, because then they were covered and people were actually seeking treatment for that and then working, and working. And so I think it's more than anecdotal in that space. There's actually concrete information that we have that we can share.
I would say, underscore everything Matthew just said, right? The Medicaid expansion coverage alone brought in more than $3 billion into the state's economy in federal reimbursement in its first 5 years. When people get health insurance after they haven't been covered, they use their health insurance. They get checked out. They're like, oh, this thing's been bothering me for about 10 years, and that thing's been bothering me. And it's true. And the utilization goes up that first year. But the utilization has a payment stream, right? They come in and they get it all checked out, and they feel better because they're like, oh, I feel better about going to the doctor because I know it can get paid for. Because people, honestly, for the most part, if it can't get paid for, they don't want to go. That's why people wait until they're really acute when they're uninsured.
And they will get help, but they are in the emergency room in the highest cost center in the hospital getting that care that could have been a $100 service at a primary care agency instead of a $5,000 bill at an emergency room. And I mean, that is reality day in and day out. And in mental health, we see that in a variety of ways, between ER boarding, which is something that we've talked about in this state a lot. You know, hundreds of people sitting in the emergency rooms waiting for a bed at New Hampshire Hospital. And then New Hampshire Hospital having 168 beds, and half of those beds are people in that hospital that can't find somewhere to go outside of the hospital. So it is just this constant cycle of just having enough access at the right level of care. So although I don't have a number for you, I think we can say that the longer people defer getting care, the more expensive care is.
Okay, we got a question over here on the edge.
I'm getting the feeling that some of this is going to end up in the laps of us hapless property taxpayers. Am I wrong or right? I'm thinking specifically of cuts in SNAP. Towns are obligated to assist with food orders if there's an emergency, number one, and then we have these big county nursing homes that seem to run chronic deficits that get kicked back onto the local property tax. Just a short answer, am I crazy or am I right?
Well, because the tax base in New Hampshire is based on property taxes, I think it's a pretty good assumption that it's going to hit your property taxes one way or another, because it's a downshift from federal government to state government to local municipal government. And what we know is that the buckets don't all get cut evenly. If the state loses federal money in healthcare, do they cut money in aid to schools? Do they cut money in other areas that the town has to pick up? So what you're going to see, county nursing homes, absolutely, you know, in county nursing homes, majority of them, 85% are Medicaid. And county nursing home, I spent 20 years at Merrimack County Nursing Home, and I know those statistics. Welfare offices, for sure, and then your local nonprofits, whether it's West Central or your local food pantry, they are all going to be struggling to meet that need in your communities, for sure.
I work in municipal government myself, and we've already seen upticks in welfare requests. And it's, you know, it's constitutional. The municipalities are responsible, ultimately. You were talking about the safety net and the chaff, and we're at the bottom down there, but we have to do something as a municipality. And so Plainfield here, everybody in this room, Cornish, we're all going to be certainly seeing increased support requests. Question right here.
Well, we've been looking at priors, what the percentages are based on. With CDC rules changing and perspective on healthcare definitions changing under JFK Jr., has there been projection about what that means for the quantity of medical need if there are some of these policy changes that affect what we're considering to be valuable healthcare?
Oh, it's really hard to stay nonpartisan with that one. So I think what I want to say is nobody knows what the ramifications fully will be of the current administration's policy. And that finding reliable data is hard now and is going to get harder. And so that's what I would like to say about that. Yeah.
I'm comfortable with saying that as a registered nurse, that I am confident that your healthcare professionals are going to continue to deliver evidence-based care and high-quality care regardless of what comes out of the current administration. The problem is going to be is will they get paid or penalized for providing that level of care?
I think it was well said.
Okay. I think we've got time for one more question. Is there anybody else in the room? There's some good cookies back there too. We're probably itching to get there. Here we go.
I want to ask about vaccines. People are finding it very difficult to get them, and if they're not in that age group, they have to have a checkup. And again, I guess the vaccines, will insurance not cover it unless your state agrees?
I might offer, Sue, that could be an entire another panel for discussion purposes, as opposed to just the implications of the One Big Beautiful Bill Act. So I demur in an answer to that question, knowing that our system is still setting up vaccination clinics. Our state still has a vaccination association, notwithstanding some challenges to it. And that, to Lori's point, I think that providers are still going to be giving you the clinical advice that they were trained to give, and those are conversations that will take place in your provider's office. And whether or not we get paid for those will still be available to provide them.
Anything further from the other panels? You good? Okay. Well, thank you so much. How about a nice round of applause for our panel? Matthew Houde, Lori Shibinette, and Deborah Fournier. I'm going to turn it over real quick here before you guys skedaddle to Sue.
I just wanted to echo, thank you so much to the panel. This is just terrific information. Your knowledge and insight is just so helpful to everyone. Rob, thank you. Terrific moderator. We appreciate it very much. And I'd like to echo your thank you to Matt Taylor for the sound and for Jam for filming this so that it can be shown on community access TV stations so we can share what we learned tonight with other people as well. And I'd also like to thank Sue and David Taylor, who really took the lead on organizing this event. There's a table by Sue over there that is our DEMS table. We'd like information on additional topics, issues you'd like information on. There's a suggestion sheet, and we'd love to hear from you about what your top concerns are and if we can help you get more information on them. There's also a sign-up sheet for our email list if you want to become more involved with the DEMS or just learn what we're up to. And our next program is October 29th. It's a town hall with our 3 state legislators. Senator Sue Prentice will be there, Representative Margaret Dry, and Representative Bill Palmer, right there. So it's co-sponsored with the Plainfield Cornish Republicans. So we hope to see you all back here on October 29th. And last, but certainly not least, thank you all for coming out tonight. This is such an important topic, and we really appreciate your interest in learning more about it. So thank you, and good night.